Hello and a very warm welcome to you. My name is Ray Lavery.
My name is Jessica Crooks.
And together we manage and run Trans Matters Worldwide and Trans London Meetup Group.
We do in-person events and online events once or twice a month. And right now we're hoping to move into webinars. We're bringing in experts and trying to educate.
That's it. And so originally this channel was actually my female to male transition line, but we have upgraded it from there. And as Jess has said, what we are going to do is we are going to do all things transgender. So there'll be fresh webinars, there'll be fresh interviews, there'll be some fun stuff if we can think about it and just record it, and things just to keep you occupied and have some fun and help you along your transgender journey. So to make sure that you don't miss out on anything, all you have to do is hit the subscribe button, and that way you will get all of the notifications of what we have coming up and you won't miss out on anything. So enjoy that, and we will see you in there. So take care and goodbye. So yes, for those of you who are watching the recording on YouTube, and if you have a question that has been answered, please put it in the comments section below the video. We will be monitoring those, and we will be able to get those questions to Chris for you. Okay, so just to so that you're all basically aware of that. So let's do the proper start then, shall we? Hello, again, very warm welcome to you all. You're all very welcome to this webinar. I can't tell you how excited we are to have the wonderful Chris Inglefield with us today. You all know out there in trans land that having the opportunity to actually talk to a surgeon without having to wait for 25 years on a wait list somewhere is a really big deal. So we were absolutely thrilled when Chris agreed to come on and do this webinar with us. And really what we want to do here is we want to get your questions answered. We're going to go through all of the basics here, but it's so important that you all out there feel that you have the answers that you need to be able to make the decisions that you want to make. And that is a very, very important thing. So for those of you who are maybe a little bit new or who don't know me, my name is Ray Lavery. On with me is the wonderful Jess Crooks. Give them all away, but I don't think they'll ever. Yeah, definitely you. I don't think that's Chris. So we are together. We run the Trans Matters Worldwide, but really it's the Trans London Meetup Group, the Transgender London Meetup Group, which is what we are doing at the moment, where we do a lot of social events and we also do a lot of educational events as well. So it's just wonderful to be doing this. So thank you all for being here with us today. Today we are, of course, joined by the wonderful Chris Inglefield. Chris is, let's be honest, one of the most renowned surgeons in the UK when it comes to transgender care. And he is a consummate professional, and not just a consummate professional doing the highest standard of care and just brilliant, but he's also just a lovely, lovely man. You know, we've had some very good chats with him, and he's very friendly, very caring, and that is exactly what you want in a surgeon. Is you want someone who really understands where it is that you're coming from. So I've just maybe stolen a slight bit of what you were going to say there, Chris, but do you want to maybe just give yourself a very short introduction, just so that everybody can kind of come up to speed on who you are?
Oh, great. And just first of all, thanks to both you, Jess and yourself, and thank you for the kind words. I'm just a humble surgeon. We just try to do our best. You know, we're very aware that giving the best possible care for our patients is so valuable for them, for their lives, their mental health, and that's what we're here for. You know, it's a pleasure for me to join you on this great exercise that you're doing. And you know, we're here to try and answer as many of your questions as we can. I'm a plastic surgeon by background, but I've been doing gender surgery for about 15 years. And we try to, you know, as Ray said, we try to give the best possible care that we can. And we're always happy to listen to our patients and make sure that we continue to improve.
Yeah, and actually we have quite a number of people inside of our group who have used you as a surgeon, and everybody is singing your praise. Everybody is. So that's, nice. I know it's nice when people say it, but, it's even nicer when in the community, everybody goes, right, you need to go talk to Chris because he's the guy for this. So that's just fantastic for us. So look, I think what we'll do is let's just jump right in, because I think as we get talking here, it will kind of spark questions that people have. So what we want to do is we're going to do something ridiculous. We're going to try and fit in all the surgery options that are available out there, regardless of how you identify. But let's maybe start with a little bit of, I guess, in a little bit of an order so that we can kind of tick things off our list here. So let's talk about, first of all, the options for female to male. Now, I know that you probably specialize a little bit more in the MTF side of things, but you'd still be very aware, and certainly within the surgical community. So the options for FTM, let's talk about sort of top surgery at the moment. So what is your recommendation? And, I guess everybody has Googled kind of what the options are, but what I want to talk about here is, I guess, more the reality of having such a surgery, what to expect, how to prepare. And I mean, I've just thrown 15 questions on you there in one go, but, what,
That's
what do you reckon?
Yeah, for me, top surgery is about you, the patient. It's not about what I like and what I don't like. We try to make sure we do the best thing that's in your best interest as a patient. The very important things to remember is what your goal is as a patient. Where do you see yourself in a kind of standard question I ask patients is, what do you want to look like in a year's time after your surgery? What do you see yourself? And everybody's got different thoughts, and it's important that we understand that. One of the very key things for me is making sure that patients understand that this is an opportunity to remove a potentially very cancerous tissue. That is your breast tissue. And therefore, my policy is that I will not leave any breast tissue at all. Our goal is to make sure we remove all the breast tissue. Whatever technique you're using, the goal is to remove all the breast tissue, because I don't want our patients to be worrying about mammograms or worrying about breast cancer in 20, 30 years' time. Doesn't make sense. It's not logical. So that, for me, that's a very fundamental starting point.
Yeah.
What technique is appropriate for you is very much depending on size, on your skin quality, and how much scars are a factor in your decision making. Our goal and my approach is to try and make the scars as inconspicuous as possible, whatever technique you use. And the two basic techniques that I use, and many surgeons around the world, is periareolar and a double incision procedure. And really, the decision about that is based on what I said previously about your size, your skin laxity, your ideas about scarring. So it's really working with that patient to get to where they want to be and what's appropriate.
Okay. All right. And so I know that there's many different options in there, and there's, I guess, like periareolar, there's also the keyhole surgery, but I think quite a lot of people don't qualify for that. And I think probably the majority of people are in the double incision area. Now, I myself was very lucky, and I was able to go periareolar. And I was told by my surgeon when I went to the US that I wouldn't have any, for instance, nipple sensation. Now, that turned out to be completely not true. I have now more sensation than I ever had in my entire life. That was unexpected. But certainly for double incision, I know that really isn't going to be an option. So what, for, I guess, from a sensitivity point of view, what do you, I should not recommend, but advise your patients?
Yeah, any breast surgery, including top surgery, there is certainly the potential that there's no sensory recovery. in my experience, and we do about 250 top surgeries a year, that most patients recover some sensation. A lot of patients get very good sensation, but it can take, like any nerve recovery, it can take 9 months to 18 months for that sensation to recover. Periareolar obviously has a better chance that the sensation is going to recover, but even with the free nipple graft, we have patients a year down the line that report to us that they have very good sensation. So
sorry, they have nipple sensation, or a sensation around the nipple area. Can't possibly be the nipple, right?
Nipple sensation.
Wow.
And that is very much dependent on that individual's healing, the lack of complications. So the better that tissue heals, is the better chance that the nerves are going to go back into reconnect in the nipple.
Okay. Wow, that's amazing. And so what about, I mean, I have heard of a few people sort of on the opposite side of the scale where they're actually experiencing, I would say, more like spasms in the nerve. So even very early on, within a month of surgery, that they're experiencing pain and it's starting to go down their arms and stuff like that. Like, is that, I would assume that's fairly uncommon, that, because I hadn't actually heard of it before.
It's not uncommon with I've done quite a few breast reductions and breast uplifts and and breast augmentations, and we always say there's a risk, but what you've got to remember is when you do that kind of extensive surgery, you're moving all the breast tissue, you're messing up all the nerves, to put it in pretty much simple terms. Those nerves take time to recover. As they're recovering, your neural system fires off electric pulses it's almost like the BT engineer testing the connections. And those little firing off of electrical impulses is what cause like pins and needle type sensation, sharp shooting kind of pains. That's a good sign, because that means the nerves are recovering. So it's just getting through that period. And then that the nerves are going to go on and get better and better.
Okay, yeah, okay. Well, that's actually, so it's actually a good sign, which is, because some people are like, oh, I didn't expect to feel any sensation, and I'm feeling a lot more sensation than I expected.
Yeah.
What's going on here? So, okay, well, that's actually a very good explanation. Now, you were mentioning there at the earlier stages about sort of making the scars inconspicuous. Now, talking with so many guys who've had top surgery, there's a huge difference between the final results, if you like, that people are talking about when it comes to the scarring side of things. So what is it that you actually do to make those scars inconspicuous? And I guess, what's your advice to people who are, I guess, post surgery, so that they get the best results from that, if you like?
Yeah. So firstly, is at the time. Are you disappearing there, Ray?
I disappeared for a second. Yes, I'm playing the part. Yeah.
Dog-related troubles.
I
I
thought
he was falling off his stool. Yeah. So the first thing is about looking after the incisions, making sure that we get the scars to follow the shape of that individual's pectoral muscle. And that's for me is a really important part of our surgical approach, because the more we can get that scar to follow the shape of the pectoral muscle, is less surgical it looks, and as it heals, as it fades, that scar becomes almost a shadow of the shape of the pectoral muscle. So it becomes very as inconspicuous. It's very similar to why camouflage works on military vehicles, because the camouflage is breaking up straight lines. It's disorientating the brain's view of that area. So it helps to camouflage the scars. The second important thing is to remember that as scars are healing, in that first 3 months, the scar tissue is like Play-Doh. It's very pliable, it's very stretchable. So if you don't support the scars, if you do too much with your arms, if you're stretching your chest a lot, you're going to stretch that Play-Doh, and that'll affect the quality of the scar that you get in long term. Yes, individual biology determines how your body is trying to heal itself. And that's something we don't have control over at the moment. There are lots of lasers and things that have been tried to try and modulate that. But in essence, your biology is the factor that we cannot really change. But what we can do is we can support that scar tissue as it's healing to get it to be as good as possible. Now, we do all of these factors, and some patients get lovely fine line scars, and some patients get broad lumpy scars. Doesn't matter what we do, because that comes down to your individual biology.
Biology and also what you do after surgery.
Yes, also how you look after yourself after surgery. If you're doing too much, if you're too early, if you're smoking, if you're not eating healthily, then obviously all of that impacts on how your body heals. So it's very I always look at it that I get to do the easy part, which is the surgery. The patient gets to do the hard part, which is the recovery, and which is this looking after themselves, looking after their scars to get the best possible outcome. Because that's a long part of the thing.
And it's much longer than people are telling. I mean, I was told, 6 to 8 weeks, or you'll be back to normal activity. No, in no way. And certainly from a scar perspective, it took significantly lower. I would say closer to 10 months before everything had sort of really reduced to a point where I felt comfortable. And certainly some of the guys who got have almost no scarring, they were extremely careful. Whereas, 10 months to a year, they were not lifting their elbows up above their shoulders, keeping them down there, tying a belt on, and that made a huge difference.
Yeah, and it is difficult for some patients, because if they have to get back to work and their work is more of a physical job, it can be very challenging. But we really have to try and support patients to look after themselves in that first 3 months, to try and optimize that period when the scar is the most risk. Important
absolutely.
for that.
Absolutely. Okay. So there's a quick question that has come in here, actually. I think it ties in quite nicely since we're talking about this. So can you make, I suppose, any comments about sort of slightly different techniques, such as the inverted T or the dermal flap, particularly one without a nipple graft?
Yeah. So inverted T, I hate, because
why?
Because it's not a good scar. And really, if you're going into an inverted T, you're better off just doing a double incision with a free nipple graft. And the reason is that if you look at a natural male chest, whatever you consider natural male chest, the distance from the nipple to where the chest is usually no more than about 1 centimeter to 2 centimeters maximum. So what you're talking about is doing a T scar with 1 centimeter or 2 centimeter vertical part of the scar, which for me is not logical at all.
Okay.
You're adding a scar which is not necessary.
Right. And that in itself is going to then, if you go and say, stand out a little bit.
Yeah, exactly. It's a potential scar that can be very visible because it's a vertical line. So why do it? Dermal pedicle. So remember, with a periareola, we always use a dermal pedicle to keep the nipple alive. Yeah. Right. So you always have a dermal pedicle. So even with so with a periareola, dermal pedicle is absolutely necessary to keep the nipple alive. Any other procedure, if you're trying to use a dermal pedicle, what you're doing is you're adding bulk underneath the nipple, and that can make it look like a cis man with gynecomastia.
Right.
Yeah.
Okay.
With man boobs. With man boobs.
Some moves going on there.
So,
I'm not sure if that would be an improvement, though.
Yeah,
really
exactly. So with all of these things, you've got to look at the pros and cons, and you've got to look and say, well, are the benefits of doing this significantly more than the downsides or the negative part of it? And I have looked at all of these. Some people talk about doing a fish mouth excision, but you end up you have a scar which is in an awful position. It's not a scar that's easy to hide, and for me, between a periareolar and a double incision procedure, honestly, I think I've seen your chest. You've got a brilliant result. The periareolar procedure, done well in the right patient, gives a brilliant result. Unfortunately, many surgeons try to use periareolar because the patients say that they want smaller scar in the wrong patient.
Yeah.
When you look at the data, the revision rate in periareolar is much higher than a double incision procedure. Why? Right. Because surgeons, either surgeons or patients, are trying to make a square peg fit into a round hole.
Yeah. Yeah, and I know that, and I have to say that my surgeon was very clear on that as well. And what she said to me was like, look, you look like a good candidate for this, but I won't know until you're standing in front of me and I can see for myself, because it's also to do with the skin elasticity. Now, a lot of surgeons had told me that it was to do with age, that I was literally over 40 years old. That's it. You have to have double incision. There's no choice. And I didn't agree with that. And I had to go through a lot of surgeons to find out the truth.
Yeah.
But it was about skin elasticity, really, is what I was talking, is really what the answer was.
Exactly. And age, for me, age is a number. Age is just a number. It's about your physiological, health, well-being. It's not about age.
Yeah. Wonderful. Okay, very good. Okay, well, I think we've kind of covered sort of top surgery for FTMs, but let's go the other direction here. Let's go for MTFs, because there's more questions coming in. We'll talk about those in a second, though. So usually in MTFs, I mean, a lot of ladies don't need breast augmentation, I guess, because the hormones do the job for you. But I mean, you of course would do a lot of breast augmentation. So what would you recommend for somebody who's looking for that? Like, is there a particular size where you would go, okay, that's big enough, it doesn't need anything, or is that a consideration for you?
Really, really important discussion, really. Because again, it comes back, it's what that patient feels comfortable with. So, we look at if they've been wearing padded bras or chicken fillets in their bra because that's the look that they want to achieve, then we have to work out, well, okay, what's the best way of achieving that? And timing, everybody talks about, well, you should be on hormones for 2 years, or you should be on hormones for a year, or whatever it is. It's not relevant. If something is like your chest is affecting your quality of life, it's something that you feel that it's worth improving, then it's about you. It's about saying, okay, how much is it affecting you now? If it's affecting you, if it's affecting your quality of life in your work, your things that you have to do, things that you like to do, things that you want to do, then why say, well, you have to wait for 2 years to see if hormones are going to give you the result that you want? Right. It's a controlling thing, and I don't believe that patients should be put into.
Is it really coming across for a control thing, or is it just kind of like, when girls go through puberty, they might have to wait 4 or 5 years to get full scenario, and then you might end up with double Ds, which frankly means you probably want a reduction because you're going to have some back pain.
Very, very important point. However, when you look at the effects of hormones in trans female patients, when they're gonna get the most amount of growth in that first year. So if they haven't got good amount of growth, it's very unlikely. Small number of patients will get double Ds, after that first year. So most patients will tell you, look, my breasts have grown initially, but they've stopped growing. And I want to do something about that. So it's understanding the patient, so, my mother never had big breasts. My sisters never had big breasts, and it's very unlikely that I'm going to have big breasts. So it's the whole package you've got to look at. You can't make strict rules on individual patients.
No, and also genetics does have a very large part to play with. And, I know that there's a lot of trans ladies out there who are like going, oh, but I need to have big breasts because women have big breasts. Well, I'll tell you something, 50% of women across the world, and that means literally 2 billion of them, are a AA or less.
Yeah.
That is statistically the fact. So, I think you're looking at too many Vogue magazines and stuff like that, would have you believe that everybody, their push-up bras, that everybody's got massive boobs. Not so.
Ray, absolutely right. Because I really try. I'm very conservative in pretty much all the surgery we do. We try to minimize and try to get people to say you don't need to have a D cup to look feminine. It's about your proportions. It's about what you feel comfortable with, and we try to take patients from the two extremes and get them into a place where they feel good, they feel that it's right for them, and it's realistic. It's realistic as an outcome, but it's also realistic about minimizing risk. The bigger the implant is, the more risk that you add to that procedure. Therefore, you're trying to manage all of those things.
Yeah. Okay, fair enough. And a question that has just come in here, actually, just in relation to that. So let's say somebody goes ahead and they get breast augmentation, but then their breasts continue to grow. Would that cause any tightness on the actual implant, or will, I guess, the skin just accommodate that?
Absolutely right.
The skin.
It'd be no different to a pubescent girl developing breasts, and everybody develops breasts at different rates.
Yeah.
If it happens very quickly, the skin is going to stretch like in pregnancy. If it happens gradually, then the skin will just accommodate that additional growth. And that's why we always try to err on the conservative side, because say, well, if you do increase by half a cup size or even a cup size in 5 years' time, it's not going to be disproportionate to your body shape.
Right. Okay. And I mean, the thing to, I guess, remember with that one, when it comes to sort of like, breast, I guess, kind of stretching, is that if your breasts become very heavy, that in itself will cause stretch marks. So there's many, many women working, particularly after pregnancy, and they have massive, stretches on their skin simply from lactation. And it's to remember that kind of thing can happen. And again, the bigger your breast, the more likely it is that you're going to have stretching, particularly if your weight goes up and down.
They're going to stretch and they're going to droop. They're going to sag.
Yes. So then you need all the push
on the side of yeah.
Exactly. Okay.
We have 3 questions here, sort of on a similar topic. So they're all talking about reducing scars. So I was wondering if you had any tips on doing that. There's a gent here who's talking about cosmetic tattooing, because I know that's a service you guys offer, don't you?
Yeah, so we do offer cosmetic tattooing, especially for like peri-areolar scars, where the tattoo artist can camouflage that scar by blending it into the surrounding skin. It very much depends just on where that scar is in its life cycle, of what you can do. So things in the first 3 months, as I said, the scar tissue is very pliable, it's very elastic. So it's very much important in taking the tension off that scar. So we recommend micropore tape. It's a 3-inch broad micropore tape on the scar for 3 months, day and night for 3 months. And that just takes the tension off the scar. So it helps the scar to heal better. And there's good scientific evidence for that. After that period, then you can start to use things like silicone gels or silicone tape, because what you want to do is to help that scar to mature as good as possible. Yeah. You're not so worried about the stretching, but you're worried about what you want to get that scar to mature as good as possible. So you can start to use things like that. Some patients we will recommend If the scars are quite red and they're very slow to get that redness out, we may recommend using a vascular laser in order to treat that redness, to get that redness down so that the scar becomes less conspicuous. So there's various things that you can use, but the fundamental thing is to remember that first 3 months of protecting the scar from tension. That's what's going to give you the best possible scars.
Amazing.
That is actually amazing. And so you had mentioned also about the silicone gel, and I know that there's been a lot of research done into silicone gel. And I have to say, I did a little test because I was told this by my surgeon as well. So I went out and I bought the silicone gel as it was coming from the States.
Yeah.
And then my sister, who had, funny enough, the scarring from, larger breasts, said, no, use vitamin E oil. And so I bought both. And then what I did was I had 2 scars on either side from basically where the drains went in. I was like, well, I'll use those. And I did one with silicone and I did one with vitamin E just to see what the difference would be. And the one with vitamin E, no scar remains. The one with the silicone, scar remains, but significantly less than it would have than it was when we started. So I know that's anecdotal. So there's a lot about silicone gel, really, isn't there?
Yeah, I think the most amount of research has been done on silicone gel because of, especially from burns patients. Yeah. We know from that vast experience with burns patients that silicone gel does work. The problem is that most other products, no company is going to invest money in research because they don't get any ROI.
Yeah, of course.
Yeah,
it makes sense.
It's a very difficult game. And testing products on scars, even looking at lasers and different types of technology on scars, it's very difficult. You can have, and I'm sure you've seen it. You can have one area of the scar that is absolutely perfect, and 2 millimeters away, the scar is red and lumpy.
Yeah.
And therefore you say, well, was it because I used silicone gel on that area, or I used vitamin D or vitamin C or any other concoction on that part of the scar? So comparative studies on scar healing are very, very difficult to really pin down on what works well, what doesn't work.
I mean, mine is anecdotal. It was just a test that I did. That's not scientific. There was no double blind test done here.
We've done that with breast augmentation scars, with breast implant scars, because they're very similar. They're very in a very similar pace. They've undergone a very similar process, and we've looked at one side, randomized from right side to left side, and at the end of over 100 patients, very little difference to decide which worked better in trying to manage those scars. So extremely difficult area.
Put everything on, for God's sake, why not? In for a penny, in for a pound. That's what I have to say on that. Now, a question that is just coming, because we're going to move away from top surgery in a minute, but talking just back to the breast augmentation, is there a way to adjust the distance between the breasts without using implants,
Tools.
Spot the dyslexic.
That's a Freudian slip if I ever heard one. The distance between the breasts is very much determined by the width of your breastbone. If you have a wide breastbone, there's nothing apart from taking a power saw and cutting some of the bone away. There's very little you can do to make a very narrow cleavage. If you've got a narrow breastbone, then great, you're going to have a very nice cleavage. Right. What you do have to remember is that as the skin relaxes following a breast implant, the skin will naturally create a closer and closer cleavage. So attempts to push the implants in as close as possible does one of two things. One is instead of the nipples pointing in the right direction, the nipples point way out, and they look very weird. Or what you do is you bring the implants in too close over the breastbone, and the implants become very visible in that area because naturally we don't have a lot of fatty tissue over our breastbone. So it is an area that's restricted by one's anatomy. And we have used in some patients, and it really is, you're talking about a small number of patients, we've used fat grafting to that area 6 months, a year after breast implants, to soften their cleavage, to help give the best natural cleavage area if they've got a wide breastbone. And that works very well because it can be done under local anesthetic as an outpatient procedure. So it's not a big procedure, but it can help soften that cleavage area.
Okay, really good, really good. Okay, and let's just say then that somebody had surgery, had an augmentation, and this just didn't reach the size that it was wanted. If you were going to go back in and sort of, I guess, do what I suppose a revision of sorts, would you take out the original implants, or would you place one on top of the other?
No, you'd never recommend placing a second implant on top of another implant, because you have a problem with mobility. You don't have control of where that implant's gonna end up. So the patient's options are to change the implants to a fuller implant, or to use fat grafting to get. And it really depends on how much of a, if it's 1 cup size difference, then that's really achievable with fat grafting. If they have enough fat to donate. So if you got a bit of middle spread that you want to get rid of, then it's a good option, because you're removing fat from an area that you want to get rid of, and using that fat to help improve breast shape or breast volume. Or you're going for a fuller implant. Okay.
All right. Well, that it kind of makes sense what you're saying there. So yeah, that would work. Now, how about let's move on very quickly just to the non-binary side of things. So obviously you could be, usually it would be somebody who was assigned female at birth who would be doing this. Is there any sort of difference to your approach for somebody who's non-binary than there would be for FTM?
For FTM?
Yeah, for female to male.
Non-binary female to male, So we do a lot of top surgery with no nipple graft.
Right.
For the majority of our non-binary patients. And again, it's about personal feelings. We see even some trans male patients who have such dysphoria for their nipple areolar complex that they thought of having a nipple on their chest is so awful that they just want a clean chest, and that's their choice. I am not against that, because again, it's your body, it's your choice. I don't tell you not to have a tattoo or to have a tattoo. The options for patients like I say, well, we as a plastic surgeon, we never like throwing away good tissue, but you can, if you wanted to have a nipple, again, the tattoo artist now can produce a very good 3D image with tattooing of nipples, in the future. So it's not a complete, you've done that and you have to live with it. There are options that are available, but certainly with non-binary patients who do not want to have an overtly male chest, you have to tailor that procedure to what they feel comfortable. For example, we have patients who don't want that scar to be so masculinized that it enhances their pectoral muscle. They want a much softer appearance of the scar. So you have to tailor that scar to what they like, what they feel comfortable with. Okay.
So basically, what you're saying is that you're listening very carefully to what the individual is saying and doing your best to accommodate them within the realms of reality.
Yeah, exactly. What's surgically feasible, what's safe for them. We do quite a number of patients who have what would be called almost a total breast reduction, but not quite a breast reduction. So you're getting them down to what you said earlier, to your A cup, to your thing, where they feel comfortable. They don't have a big chest. They don't need to wear a bra. They can wear a t-shirt and feel comfortable, but they're not overtly male or female.
Right. Okay. So in other words, it can be, if it's thought out well, it can be adjusted to give people the results that they would prefer.
Exactly.
Great. Wonderful. So one tiny question came in here on breast, but I do want to move on to the other side. So, and I'm not quite sure if I know what these things are. Are internal mesh bras a waste of time?
Internal mesh bras.
Mesh bras a waste of time?
Waste of time is a very strong statement. I think they're oversold.
Right.
And the reason again is you've got to balance that benefit versus risk. When you use an internal mesh, you are significantly complicating the procedure, and you are exposing that mesh to potential risk at some point. So you have to weigh that balance about whether are you trying to use the mesh to support the breast because it's sagging? It's sagging because the skin isn't very good and the weight is too much. So shouldn't you be thinking about reducing the weight so that you protect the skin rather than trying to put in an artificial mesh, which is it's going to support the breast, but you're overcomplicating a procedure. You are putting that patient at risk of infection.
Right. It's also a foreign body. Would there not be some rejection?
Exactly. Yeah. So you're adding that risk, and you have to then say, well, is the benefit going to be significantly better for that patient? And I think a lot, some of these things are over marketed, they're oversold to patients. I think that that they're going to get the perfect result by using an internal bra or mesh procedure. And we've learned a lot of this stuff from breast reconstruction following breast cancer mastectomy. And you have to look at these things very carefully before you jump down those roads.
Okay. All right. So think of the physics and the reality of it much more than just the aesthetics of it, I think is really what you're saying here.
Exactly. Yeah.
Okay, wonderful. Okay, so let's move on to bottom surgery, and I guess let's start with sort of the FTM, because I know there's a couple of questions from the MTFs here as well, and I know you have a very strong opinion on the right version of bottom surgery for MTFs. But so what I was saying is, the surgery for FTM, to be honest with you, when it comes to the aesthetic appearance of it, it doesn't seem that surgery has quite hit the mark as of yet. I know that there's a lot of work that's gone into the sensitivity and looking from different donor sites and stuff like that. But what is your opinion on this? And I guess, what are your thoughts as to how things can improve?
Yeah, Ray, it's something that I have wrestled with for most of my career. I don't think that the surgery that we have available for phalloplasties now are really in the best interest of the patient, and that's my bottom line. I think that we need to take a step back and look at what does that patient want, what are their goals, and how do we get there?
Right.
As you said, there are lots of donor sites. Everybody will say now that the gold standard is the radial forearm flap.
Yeah.
Yes, it's great, and you can get sensitivity because you can use the nerves from the forearm to connect to the dorsal nerves of the penis. So you can of the nerves. So you can help with get better and better sensitivity, and that's where the science is going about nerve regeneration, about things that we can help to promote nerve regeneration. But for me, it's a very getting a good functional and aesthetic outcome for FTM patients is, I think it's a journey that's much harder than us doctors would like to tell patients, because of the number of surgeries, the complication rates, the donor site, morbidity, wherever you take that bit of tissue from, it's got to leave that patient with something that they're not embarrassed to expose, or they're not going to be self-conscious about that. They feel comfortable about their pubic area, but they're very self-conscious about where that tissue has been taken from. You're exchanging one problem for another, and as a plastic surgeon, it's something that's fundamental to our being. Is that yes, you can do a great reconstruction, but you mustn't devastate the area that you've taken that tissue from.
Right. And that's, I guess, is the thing, because I have seen particularly sort of like the ATL. So this is the coming from the quads, if you like. Wow.
Yeah.
It looks like somebody came at them with a chainsaw sometimes,
Well, it looks like a shark bite.
Yeah, it does. Yeah.
It looks like you've been tapped by a shark, and for me that's a price too high for the patient to pay.
Yeah.
And it's we as surgeons have got to get better at what we're doing, to really provide patients with a really realistic option for FTM.
Yeah, the Lastimer Dorsey, it seemed to be quite a good option. And I think there's only one guy who does it at the moment. I can never remember the chap's name, but he's at Serbian and Mount Sinai, I think, in New York. And I think your guy Giuseppe is working with him as well. He was mentioning that when I spoke to him a couple of weeks ago. But so that one would seem, from sort of the donor site, to leave the least amount. Yes, you've got a big scar, but you don't have a shark bite. You also don't have to take a skin graft from somewhere else in order to cover up what you've just taken from. So it seems a better option, but you're going, So what are your thoughts on that?
Well, yeah, I think it's, the latissimus dorsi donor site has been a workhorse plastic, a reconstructive surgery. It's a workhorse because it's a pretty good donor site. It doesn't have a lot of downside. Yes, there is a scar, but you can, if you look after that scar, it can be a very acceptable scar for most patients.
Yeah.
The problem with the whole process, as you know, Ray, is that getting to the point where that patient doesn't need any further surgery is a difficult road. From the urethral reconstruction to the prosthetic implant, to testicular, scrotal sac reconstruction, to testicular implants, that whole process can be a very challenging road for a lot of patients, not only in their physical recovery and getting to that end point. As you say, it takes 10 months for perioral
I know, right?
recovery.
Yeah.
Well, can you imagine 10 months 4 times in that patient's journey to recover? That's a big ask.
Yeah, it is. It is a big ask. Okay. So basically what you're politely saying is we've got more work to do. We don't have the answer just yet. The best is what's available, but I'm afraid you're going to look like a shark bite, and you're not going to be able to hide that. That's what you're saying.
Yeah. Well, and I think patients need to be told realistically what that journey is going to be like. And it cannot be sugar-coated. It has to be, you have to be, out in the open of what that journey is going to be like. And I think that we have not, surgeons, we as surgeons have tried to sugarcoat that whole thing. Oh, but think about the result. Think about the result. No, I think you've got to be much more open and honest about what that journey involves.
Right. And I think that that's a very honest answer. And thank you very much for that, because I know that obviously there's a lot of surgeons who are touting their technique as the best techniques. And it goes from, I mean, the abdominal flap is coming back, for instance, but, the radial arm, which is the gold standard at the moment, but there's so many nerve damages in the hand and it looks so awful afterwards. And then you've got the ATL where, you've got that shark bite. And this one seemed like the better version, but you're like going, there's other things to consider here. Okay, well, that's good. Good to know. I mean, at least you're being honest about it. Thank you for that. Thank you for that. Okay, so let's move on to MTS. There's a few questions that have come in here now. There's lots of different options. In fact, there's way more options available for MTFs than there is for FTMs. That is for absolutely sure. What is your take on that? And I guess, what do you recommend out of those? Because we can't really go through all of them because there's so many of them between vaginoplasty and vulvoplasty and et cetera, et cetera.
Yeah, I think for me, again, it comes back to the patient. What does that patient want to achieve? So, most patients want to achieve a cosmetic result that they can go in any environment, whether it's in a personal social environment, whether it's in a female gym, whether it's on a beach, whether it's in a nudist camp, whatever your choice is, you should be comfortable enough to go into any of those environments and not feel that people are staring at you because you look different. Yeah. That's most of our patients' goal. Second thing is, do you want to have vaginal penetrative intercourse or sexual pleasure of whatever sort? And therefore you have to decide, well, what do you want as in terms of a functional vagina? So that's very, very important. So if you take the patient who wants to have a functioning vagina, to have penetrative sexual intercourse, then you have to provide a vagina which is a suitable caliber and depth. For me, the majority of patients, a penile inversion procedure is never going to achieve that. Yeah. So I'm very much looking at what is the end. It's like FTM. What is the end game? And therefore, what is realistic for that patient to achieve that endpoint? Yeah. And for me, the majority of patients, yes, some patients get a great result from a penile inversion, but the biggest experience in the world is a penile inversion. It may be an easier operation, but it doesn't give an adequate depth. And it's either going to be tried to be augmented or enhanced by using a skin graft. Skin grafts in the pelvic area always shrink down. So you may start off thinking, I've got a great depth and I've got great size and I can do whatever I like. But over time, that skin graft will contract down and you will lose depth and you will lose it. And the same thing happens with peritoneal pull-through or peritoneal flaps, because it's not a normal skin tube, and therefore it will shrink down. Okay. So you have to look at these things in the long term.
Yeah, because I have to say, there was a discussion in EPATH, and there was a few surgeons there, and they were talking about, having had patients having had vulvoplasty and then wanting to have a vaginal canal later. And they were like going, well, actually, people are saying that you can't do it. But in actual fact, there were two surgeons sitting behind me who's like, yeah, it's very easy to make a cavity. Keeping it open, not the same thing. So that
Exactly.
was what they were basically saying.
Yeah. In order to keep that cavity open, yes, creating that space is tricky, but it's doable. Keeping that space open is the challenging bit, and you need healthy vascularized tissue that has its own blood supply in order to maintain that tube. And that's why, for me, my go-to procedure is the penoscrotal flap procedure, because you're creating that tube out of tissues that have their own blood supply, they have their own nerve supply, and they can remain intact. For those patients who've had a vulvoplasty and have lost depth, or they've had a complication, whatever, and they need a redo or revision procedure, the best procedure to use is using a segment of their bowel, because that has its own blood supply, it's healthy tissue, and it will maintain that cavity open for that patient for the rest of their lives.
Right.
So, we, again, as surgeons, we always like to innovate, and we like to try and do the best thing. But what we've got to be very, very cognizant of, and be very honest with ourselves and with our patients, is where are you going to be in 5 years' time? How is that vaginal tube going to be in 5 years' time? And I see so many patients that have had all of these, best procedures in the world come back, and they've only got 3 inches of vaginal depth. They're very difficult to dilate. They have to dilate every week. Almost some patients who are dilating 3-4 years later, they're dilating every day. Well, you must have a very good job if you can spend 2 hours or more dilating every single day. And that's the issue for me, is that for you to have a viable result, you need to be able to feel that you don't need to maintain your vagina in order to keep a functioning vagina.
Yeah. Okay. So your penile invert, the gold standard, as you would say, is not really the gold standard as it turns out to be, from your opinion. Okay. So the other big thing I think that also comes up for bottom surgery for MTFs is the lubrication. Particularly, we're talking about sort of the vaginal canal now. And what are your thoughts on that?
So really, really interesting topic. And the way, yes, everyone says that by using, whether it's a penile inversion or whether it's a penoscrotal flap, it's skin, it doesn't, you won't get any natural lubrication. But what we've learned is by starting our patients on intravaginal estrogen as early as 6 weeks, that tissue modifies, becomes a lot softer, a lot more vaginal canal-like, and it doesn't happen in 10 months. It can take a year to 2 years for that tissue to really become softer and more natural, and it becomes more self-lubricating, because it's no longer the skin barrier layer becomes a lot more porous to fluid coming through it, and it becomes much more self-lubricating.
Okay, which is a very good thing, obviously. So, that's what you want. And so, in fact, somebody has asked here, just kind of leading from that one, they wanted to ask him, and I don't know what this is actually, clasper's organ. And they've heard that having this being included in the opening actually allows the neovagina to be self-lubricating. Is that the case?
Yeah. Well, they are essentially sebaceous or sweat glands in the perineal area, which provides natural moisturization in all of us, and it's using those glands in order to provide. We do what we forget is in FTM FTM of MTF. Sorry,
yeah,
I'm getting confused.
It's always a bit of a tongue twister, isn't it?
Yeah. Is that we're not removing the prostate, so we're still getting prostatic secretions coming out of the urethra on sexual stimulation, on sexual excitation. So you're still getting that natural secretions, which everyone produces from their prostate. So which is very comparative to the female glands around the introitus, around the the genital area. So I think that there's a lot of negative things about moisturizing and natural lubrication, and I think that it's one of those areas that this medical community haven't looked at the science behind it to say, well, what can we do to help improve that? But from our experience, probably the most significant thing is healthy tissue, so you minimize scarring. Secondly is the introduction of intravaginal estrogen after their surgery to help promote that whole healing process.
Okay. All right. So there are things that can be done to help the body heal in a way that improves your chances, basically.
Optimizes. Yeah.
Yeah, exactly.
It's talking about optimization.
Yeah, exactly. Optimization. So I guess not quite the last question on this, but just going for the non-binary when it comes to bottom surgery. Now, this tends to be in the case of nullification. Now, I'm not sure if this is an area where you have done anything on this, but I mean, what would be your understanding of getting a decent result from that? And
again, a very interesting area, because it's something that a lot of the medical community have kind of pushed away, because things. But again, it's about that patient. What does that patient want to feel like, to look like? I do quite a number of just vulvoplasty, and that vulvoplasty can have it's a spectrum, much like the rest of the human race. It's a spectrum. It's about, obviously you need to create a urethral opening. That's vital for your
survival.
Apart from that, everything else is what does that patient want to achieve, and therefore, as surgeons, we need to be realistic and say, okay, well, this. Are you sure this is where you want to go? Because once you remove that tissue, there's pretty much no going back. It's getting into the realm of female genital mutilation. That you don't want that patient to get 5 years down the road and feel that they have been mutilated, and that's really, really important to make sure that you understand.
Surely would be true for anybody assigned male at birth who wanted nullification. It's almost the same thing, right? You have to remove a penis. So
exactly, absolutely.
Yeah. Okay. So the options are there, but the point I think on this is to be very, very careful. And this is definitely not a light decision, because, as you said, once you take that tissue out, there is no going back.
Yeah. And that's why the support is important. And I think that what yourself and Jess are doing is talking about these issues, getting it out there, helping patients to understand where they want to be in life. It's not about imposing rules and protocols and processes on them. It's about helping that individual work out, where do I feel comfortable? Yeah, and that's so important, that not to rush into these things, not to be pressured into these things, to make sure that all of us in the community have a responsibility to make sure that patient makes the best decision for themselves.
Yeah.
And not because.
But they also think of the future. And I think that's the thing, is like, where will you be in 5 years' time? And I think that is a very important question to ask. And frankly, it's not one that I've heard a lot of surgeons talk about, because they talk about, well, the result that you'll have in the next 6 weeks or whatever, or a year down the line. But that's sort of like, well, hang on a second, let's think about your life in 5 years' time. Are you sure? Now, nobody knows the future. We're flipping a coin when it comes to what we're going to do in the future, but at least to have just thought about that. For instance, not that it's relevant, maybe it's slightly relevant to this conversation, but, people who, have not thought about, not fertilizing,
Fertility preservation.
fertility. Yeah, exactly. So there you go. Thank you for picking the right words there. That type of stuff where you think, well, I'm 22, I don't want children. And then you're, 32 going, shame. So, it's that thinking ahead. And it's funny because Mary talked about this quite a lot in her seminars as well. So, it's a very big one. So, yeah. Okay. So thank you very much. Sorry, Chris, you wanted to say something there.
No. As I say, it's so important to look forward. Yes, you cannot predict, as you said, you cannot predict where you're going to be in 5 years' time. We all try to plan and try to think, well, okay, what do I want to achieve in my life? But you cannot predict where you're going to be. And when you come to vaginoplasty, I very much get our patients to take a step back and think about where they want to be. If they say, look, I don't want a functioning vagina, we'll say, well, are you sure? Are you really know in your mind that in 5 years' time you're not going to meet the man of your dreams?
Yeah.
Let's put it down to pretty basic stuff. And therefore, don't burn that bridge unless you're really sure that that's where you want to be. So it's helping. I don't want to impose my will on anybody. I'm here to support. I'm here to try and do my best for any individual. But we also have, as a community, we have a duty to try and help that individual make the right decision for them now and for their future.
Okay, brilliant, super stuff. Chris, there's quite a number of questions that they're starting to sort of mount up in here. Like, we've gone over time, but do you mind answering some of these? Is that okay?
Sure. Yeah,
fantastic.
Just a quick fire.
Yeah, good. Do you want to just do that? Because I know that you've been monitoring them much more than me, Jess.
Cool. So I'll hit you with as many as I can. Okay, let's start. Do you have an opinion on metoidoplasty?
Yeah, absolutely useless operation. Simple answer.
Sorry, useless operation.
Useless operation.
As in no function whatsoever. Why did you bother?
Yeah.
Why do you think that now?
Because I spent my young life as a plastic surgeon trying to reconstruct micropenises in young boys that had no genital development.
Right.
And I think I think it's a completely useless operation.
Okay. Again, thank you for your honesty. That's good to know.
Honestly.
Yeah. Okay.
And that's how I technically, yes, I do, but I would never offer it to a patient.
Right. Okay.
Okay. What is the recovery process like for orchiectomy?
Very good question. I think bilateral orchidectomy is a very good procedure for patients who don't want to take testosterone blockers. It's a pretty straightforward procedure because I do a very small incision to remove both testes. And the main thing is restricted activity for the first 2 weeks. We provide a support garment to reduce swelling, reduce bruising in the area. But it's pretty much getting back to normal day-to-day activity after 2 weeks, but no vigorous, no marathon running, no heavy gym work for 6 weeks.
Okay.
So we got a question from Joe. Would you perform revisions on patients that have had surgery with other surgeons? Is that something that you guys offer at the clinic?
Yes, I think that as for me as a surgeon, as a doctor, I will always try to help an individual, but I'm also very, very honest and realistic about what's achievable with revision surgeries. I'll be pretty blunt. I cannot make a silk purse out of a sow's ear. So if you've had a devastating procedure or complications, then I will certainly do my best to try and improve things for you. But I will never promise a patient that they're going to have a perfect outcome when you come into revision procedures.
Okay.
Good to hear.
Yeah, definitely. We've got an MTF woman here who has had the orchi surgery. She says she's developed neuromas. Now, what was recommended was, just reading here, having the spermatic cord removed where it enters the spine. Have you come across this problem before?
Spermatic cord, where it enters the spine. The spermatic cord does not enter the spine.
Well, that's what a local urologist has said to them. So that it sounds like they need a better opinion.
Yeah,
it sounds like you need another urologist.
It sounds
Basic
like
anatomy
not
there.
had a very good orchidectomy.
Yeah.
And one of the very, and in fact, I was showing the guys on yesterday, or we did a gender MTF yesterday, is exactly the nerves that can be damaged at the time of an orchidectomy. And really, if they've got a neuroma problem, then somebody needs to go back in and find those nerves and bury them so that they avoid. And what we tend to do with, if a nerve has been damaged, is either reconnect that nerves to avoid a neuroma formation. If the nerve has been divided completely and there's not a possibility to reconnect those nerve endings, then what we do is we bury the nerve deeply into the muscle layer, so that even if a neuroma does form, it's not going to be hypersensitive, which is what most neuromas become. They become oversensitive. So the way to avoid that is to bury the end of the nerve deep into the muscle layer.
Right. So actually, what they had meant there was not the spermal cord; it was the nerve entering the spine, that they were going to cut it at that point.
Yes, yeah, which is not the thing to do.
Not the thing to do. Well, it's right on the spinal cord. You want to be careful about that.
Yeah. Very unnecessary.
Right.
So for female to male bottom surgery, do they not use pedicle for penile construction? That's the question.
Yeah, you can use pedicle flaps, and that's what Ray was referring to, the abdominal flap. It's a pedicle flap from the abdominal tissue. So it's like the tissue that you would remove for somebody having a tummy tuck. You're using that tissue to reconstruct the penis. It's a good procedure because the area where you've taken the tissue from is very good, because it'll be like a tummy tuck, a scar. The problem with that tissue, it can be very bulky, but it's also almost impossible to get nerve sensation back into that tissue. So you win on the side that in fact it's a good area to have a scar, but you lose on the fact that the tissue is not really ideal to create a penis.
Right. Okay, because it's about the sensitivity on that. So, I mean, obviously you have a bearing of the clitoris, which will give you some if you're rubbing in the right areas, but, actual sensation, cold, hot, that type of stuff, not really going to exist.
Yeah.
Right. Okay.
So second to last question, have you looked into the techniques used by supporn/bank? So particularly techniques of increased depth and self-lubrication.
Yeah. So I hope supporn doesn't take offense, but supporn started off doing penile inversion, and he realized very quickly that actually depth was a major problem with patients. That's why he started doing penoscrotal flap procedure to ensure that you get the maximum depth with a good caliber vaginal tube, and that's been the main technique of many of us around the world, to ensure that you get a vagina that does not need maintenance, does not need a revision procedure in 5 years' time or 10 years' time. The whole issue of self-lubrication is about ensuring that you have healthy, viable tissue with minimized scarring, that becomes as natural when I see patients, I see because the different surgeries that we do when we see patients 5 years down the line following vaginoplasty, and you have a look inside that vagina, it looks very, very similar to a natural female, cis female vagina. So that for me is the icing on the cake.
Amazing. We've got, I think, quite an interesting question here. So we have a non-binary assigned male at birth who's asking, could a vaginal canal be formed with the scrotum whilst maintaining a penis?
Yes, technically very possible. Again, you have to, that requires a lot of counseling, a lot of support to understand where that patient wants to be, in their life. But technically, yes, possible.
And then the last thing I wanted to say is we've got two people here, 6 months and 3 weeks out respectively, who've had top surgery with you. We just wanted to say thank you so much for
Lovely.
And that's what we'd like to say too. Thank you so much for coming and doing this, Chris.
That's what makes it all worthwhile for us is, I saw 2 patients today who had their top surgery, periareolar ray, maybe as good as yours, who had the periola, with us over a year ago, and they're just over the moon. Their chest looks fantastic. You would never check them out, So it's why we love what we do. It's why we really push ourselves to try and improve and do the best we can to understand our patients more, to make sure we're doing the right things for our patients.
And and you are, based on a lot of comments that have come in on the chat, on the Q&A, people going, okay, Chris is brilliant. So thank you so much. And I have to say, as Jess just said, thank you so much for spending the time. I know it's been a very long day for you, and then you come back and you do a webinar, and it's like you got up at 8 o'clock in the morning and you're fresh as a daisy. So I don't know how you do it. I hope there's a good stiff whiskey or something coming later so that you can sort of relax for the evening. But, thank you so much for taking the time, for explaining all of that, for going through and giving answers that are very difficult to get from surgeons, and not sugarcoating things, which I think is a very, very important thing. We'd all love to believe that the optimum is possible, but it's very important that you understand the reality, because as I said at the beginning, you're going to have it for the rest of your life. You want to be very careful what you do, and ask a lot of questions. So it's amazing to have somebody with your caliber and experience coming in and being prepared to being so honest, which is amazing.
Ray and Jess, thank you for doing what you're doing, because I think it's the more we communicate, the more we talk, the more we share ideas, the more we ask questions, is the more we learn, and the better we are at what we do. So I'm just a humble surgeon, and I will say it again. If you tell me I'm doing something wrong, then I will work out how to do things better, and that's what we got to do all the time.
And that is the thing, it's just keeping your finger on the pulse and keeping improving things, not just like, well, I know the technique, I'll just keep doing that. It's that continued innovation that makes all the difference, and that's what makes the really good surgeons stand out, is that they never stand still, and that's a big thing, and not all surgeons are in that camp. So thank you so much for doing that, and again, thank you for today.
Pleasure.
You are fantastic. We are big fans. Yourself and Mary, just absolutely fantastic. So thank you so much for today. And look, if there's anything that we can do, let us know, because believe you me, as the questions filter down on YouTube and stuff like that, we'll be passing them to you. So fantastic. So thanks again. And everybody else, thank you so much for watching. As usual, when we have somebody like this caliber, and we go over time massively, but I do hope that you enjoyed it, and that we answered all of your questions. And again, even if you felt that you were a little nervous to put your questions even in the chat, because I know some people are in that, please just either text myself or message myself and Jess, and we will get that in, or like I said, just put a comment on YouTube if you're watching this on YouTube. So other than that, everybody, thank you so much for being here. Again, Chris, thank you so much. Everybody, enjoy the rest of your evening. Thank you so much. Take care and goodbye.
Enjoy the rest of your day. You might not be evening.
It might not be evening, that's right. It could be first thing in the morning, depending on when you're watching this. Yeah, exactly. Wonderful. Okay, take care,
Bye,
everybody.
guys. Take care.
Yes, and goodbye. Bye-bye.
Bye.
Thanks so much for watching. Please subscribe just so you won't miss out on anything we do. Thanks so much.
Bye.